in general. Because if historically when we do an open operations, people G-tube dependent, trach dependent for really long time. After we do, for example, CO2 laser excision of even, especially simple tumors, there is no downside whatsoever. People can go home, what, 2 days or so, and historically they would stay in the hospital for 2 weeks. Right now they go home in 2 days, 3 days. You know, I've done a base of town T1. It's a small tumor. Again, the success is smaller the tumor, better it is. You know, but I've done a base of town T1 with neck dissection. Patient went home in 3 days. You know, but historically it was like 2 weeks. You know, that's how it was. Right now it's that's the concept. It's different. It needs to be done properly in proper combination. Definitely whatever patient decides, because patient knows his or her situation better, social support around, surrounding, you know, kind of moral support, and patient usually decides what to do. And I always follow patient's decision. You know, but I express my opinion, what I would prefer and what I would suggest. But if patient decides to do that, I'm always happy to follow the patient. So cancers 20 years ago and now two different things. Although presentation is the same, approach and treatment is different. And depending where cancer is, different behavior and different treatment would be. So you have to remember about that. So every time you hear something about cancer or somebody gets cancer, you know, encourage to read about that, kind of look into that a little bit. I know that it's a time for panic and being lost psychologically, but vice versa, it's time to kind of concentrate and focus on it, because we're improving. We're not staying in the same place and doing the same thing. We're improving, and our survival better, local regional control better, and outcomes better. So pretty much that's the point. It's not hurts as much as it would be in open surgery. My presumption would be that he had a really small cancer, and it was resected. Well, usually when it's really small in a tonsil or base of tongue, it's resected, and you don't need to get any radiation to that. It's when it's bigger cancers. And as Dr. Hoy said, teeth stage 3 and stage 4, this stage 4 is an ultimate stage of cancer. We're talking about big cancers. And I participated in this study. And we did get 92% survival there. And it's a huge step forward with, in fight with cancer. Because historically, chemoradiation treatment for oropharyngeal cancers would give you maximum 60%. And 60% with significant post-treatment side effects lasting for several weeks, G-tube dependence, and so on and so forth. With transoral laser microsurgery, that's a huge step forward. 92% disease-specific survival, it's huge for stage 4 cancer. So that's pretty much brief overview for you guys. Thank you. Yes, we do. We are working on it. As you could see, it requires a lot of instrumentation, special microscopes, kind of proper setup. We're getting there to ultimate. But for T1, T2, we easily can do it. For bigger cancers, I would require a little bit more equipment-wise support. No, multicolor. Anything what you can imagine, purple, red, yellow, anything. Most commonly, pre-melanoma-like lesions or so-called lentigo maligna or lentigo maligna melanoma. Most common lesion usually present people 60 to 70 years old, usually males, present with a location right here. That's the most common. So if you see any light brown spot, irregular one growing, that needs to be checked out. And checked out with punch biopsy, not the shave.
Is it scabby?
No, scabby, usually actinic keratosis. That's the typical presentation, or old spot that would usually people call it. scabby looking. And actinic keratosis is also considered to be pre-malignant lesion because it can turn into squamous cell carcinoma in 10% of cases. So it needs to be kind of checked and watch out for, kind of keep an eye on it. But usually melanoma is not scabby. More, in case it presents with some irregularity to the surface, it's usually ulceration, which is not really a good sign. Squamous cell carcinoma.
Showed on a gentleman's lip.
Yeah.
How far advanced was that? If you had that for 6 months or a year?
Well, recently I had patients, one had something like that for 4 weeks, another had smaller than that for 6 months.
So there's no way of telling.
No. Less aggressive, less growing or speed-wise growing it is, better it is. It means it's not really infiltrating and going. It's like organized in there.
This was very interesting.
Thank you. I hope you got something out of it. Yeah, but again, as I said, it was kind of difficult to me because what am I going to talk about? You know, it's like huge topic. Yeah.
Will you do this again?
Well, I'll be happy to if you're interested in that. We can talk about anything. We can talk about thyroid cancers. We can talk about, well, salivary gland cancers, kind of, or we can talk about thyroid disease, let's put it this way. I'm not really keen on talking about medical treatment of it because it's usually endocrinologists and medical oncologists who are dealing with that. But surgical-wise and cancer-wise, I'll be happy to talk to you. You know, we can talk about sinusitis. You know, it's a really like hot topic. You know, because when people come saying, well, what brought you in? My sinuses. Okay, yeah, you know, because everybody has sinuses. You know, well, what's going on with sinuses? And then we start talking about pressure, drainage, heaviness, and it matters because well, as simple as severe dryness in the nose can cause headaches and facial pressure to severe sinusitis or even a cancer can cause facial pressure and headache. So we can talk about that. It's up to you. Yes?
Where did you say you were from?
Originally, it's an eastern point of Ukraine called Lugansk. If you look at the map of Ukraine, the most eastern point there, that's where I'm from. Yeah. Okay, thank you. Thank you, guys.
Thank you.
Thank you.